starting with some case for the young surgeon. So when you finish training and you go out for work, so you get some idea. The case one, 75-year-old woman, underlying of diabetes and hypertension, dyslipidemia, present with aortic dissection, hemodynamically stable, aortic root synapse is about, the synapse size about 3 centimeter, STJ about 3.5 centimeter, mild to moderate AI. That's come to you and what you're gonna do. The second one, 42 years old, Marfan patient, present with aortic dissection, type A, vital sign at that time, the blood pressure is about 70 over 20 millimeter mercury, and internal tear at the sinusoidal junction, severe aortic regurgitation, dilated aortic root, cerebral salva 6 centimeter, STJ 6 centimeter. So what you're going to do in that? The last case our team just got consult is 30 years old woman, third trimester pregnancy, presented with acute aortic dissection, severe aortic regurgitation, aortic root sinus valsalva is 4 centimeter, and non-Marfan patient. So that's all. That's the case that you're going to have to deal. So I keep the topic that how much should be done. Should we do much or less? So we know that the technique to do this kind of case is composite valve graft, aortic valve sparing, as we learned from Dr. David, supracoronary graft, and for the distal, we do open distal clamp technique or clamp technique. This is already a picture, the cartoon show all the technique that we learned. But I went to review and to try to find how much should be done, but I can see any textbook or any article that write about how much it should be done. There's no room for that. We always know that the principle of operative treatment of aortic type A dissection should be reconstruction and replacement of ascending aorta to prevent rupture, and correction of the aortic valve incompetence in terms of resuspension, composite valve graft, aortic valve sparing. But still, when you deal with the case, you still need more experience, and evaluate yourself. I was lucky to learn many things from Dr. David. One day, I asked him about what would you do lots of many surgery. So how can you decide that which one is matched which this patient? He told me only one word: Joe, you go to read. Read a lot, as much as you can. And that's summarizing your idea, and then you can get that how the surgeon did the case and what the result, so you can know that what they have done before and the result, so can you summarize with your patient and evaluate your status, so you can do the good case, and the safe for the patient. So I went to review all of this one from the Stanford paper, Cleveland Clinic paper, and from the group from Europe. I'm going to show you about the natural history, the result of surgery, and long-term outcome. So you can have some idea that those 3 cases, what should be done for that one. Natural history, we always know that the mortality of aortic dissection in the early hour is 1 to 2% per hour. And the mode of death is fault aneurysm rupture. This classic paper that show about the type A dissection with the medical treatment, the mortality rate is very high. When you compare with the surgical treatment, it's come down almost half that. In terms of type B dissection, with the medical treatment, you can see that it's about 12 to 15%. Compared with the surgery, it's about almost 30%. And the graph show that the percentage predict of the survival and the death in terms of type A and type B, and the predict of the death of type A is constant. In terms of type B is increasing every year. What the result of the surgery? Even you send to the center, the big center that doing a lot of aortic dissection, they still show that the result of the surgery still vary. The mortality rate is vary from 5 to 43% from the report, from the literature. And from the IRAC study, from 18 centers for 682 patients, they show that the mortality rate for the surgery for type A dissection is 25%. And time-related survival, Dr. Crawford showed 5-year survival after surgery. Survival is only 46%. From Stanford group showed that 55%. These data show that in terms of normal population and of type A dissection after surgery, you can see that for type A dissection, survival is about 50%, compared with the normal population is about 90%. Most of deaths from the patient who got operation, they will die early with the hemorrhage and cardiac failure, brain injury, malperfusion syndrome, myocardial infarction, and stroke. And for the late death, 30% will get aortic rupture and aortic new dissection. What is the risk factor? From the literature that I searched, I found that the acuity, we found that hemodynamic state, patient that need pre-op resuscitation is more severe than acuity of the disease. And the IRAD study showed that patient who present with shock and cardiac phenomena has high risk for the premature death. The location of dissection, as you know, that 5-year survival is different. Comorbidity. The patient has old age, over than 70%. The mortality rate is very, very high. From the IRAD study showed that patient who got previous aortic valve replacement, preoperative limb ischemia, diabetes, preoperative renal failure, preoperative resuscitation, that has high risk of surgery. Procedural risk factor. In the earlier date of the operation, the mortality rate is very high. At that time, in about 2000, 1990 to 2000, the mortality rate is over than 50%. But if you go look at the new paper that present during this date, the mortality rate is come down to 20-25%. And if the patient needs inclusion of the arch in the repair, there's a risk of the death. The need to use of composite graft technique, concomitant CABG, or prolonged CPB. Post-operative risk factor. If the patient develops post-operative cardiac dysfunction, neurological complication, or need hemodialysis, that's all the risk factor for the death. This paper for Mark Moon from St. Louis that show about the late reoperation. He studied in 201 patients during 22 years period, and they found that a non-resected primary care, Marfan syndrome, elevated systolic blood pressure at follow-up, and absence of beta blocker therapy that increased the risk of the reoperation. This study from the group from Netherlands in the European Heart Journal, they show about the aortic acute type A dissection, long-term result, and reoperation. Study about 232 patients and found that the patient who came with need the P-op resuscitation and prolonged CPB time, that increased the risk and the rate of the death. And in conclusion, they say that acute type A dissection, during this time, it has an acceptable operative mortality risk and has satisfactory long-term survival for hospital survivors. These factors were both associated with lower 30-day mortality. A substantial proportion of patients will require the operation on the valve and the aorta. This is the last paper that just published in 2014 in Circulation from the group from Joe Valeria that show about the type A aortic dissection in Marfan patient. he tell about 132 patients in two big heart centers in Germany and US. And they show that emergency surgery for type A dissection in patients with Marfan syndrome is associated with low in-hospital mortality. Failure to extend the primary surgery to aortic root and arch repair leads to a highly complex clinical cost. Aortic root replacement or repair is highly recommended because suprachoroidal replacement is associated with high needs, over than 40% of root reintervention. That's for Marfan for the Marfan patients. So what's after that? After the surgery, we can review, and we found that the fall lumen after repair of type A dissection still has a fall lumen patent in 70 to 80% of patients, and among the survivors, 50 to 60% aneurysm dilatation in 10 years, and 25% require reoperation. The risk factor for aneurysmal dilatation is patent or wide false lumen, larger aortic diameter early after repair, Marfan syndrome patient, hypertension, younger age, and male sex. That can shrink. The shrinkage can occur in 30% in 3 years, and almost occur in the patient with a thrombosed and narrow false lumen. This paper from Dr. Crawford showed that patient fit almost 25% needs for distal false lumen aneurysm surgery. Redissection. The patient can have redissection 30% after surgery, and those increase in Marfan syndrome patients. Aortic valve. Study from Stanford showed that successful resuspension of aortic valve not increase the risk of the operation. And actually freedom from reoperation on the aortic valve at 6 years. 90%, 94% on the resuspension therapy, and 100% for composite valve graft, 88% for separate valve graft and ascending aortic graft. So 5-year freedom from reoperation. From the Stanford group, they quote about 83%. From the Cleveland Clinic group, they show about 90%. And they just mentioned that increase 2% per year after the first 3 months. And from Dr. Crawford group, it's 75% freedom from the reoperation. So we know that the patient has a preoperative aortic regurgitation, Marfan syndrome patient, patent false lumen, large initial aortic diameter distal to the repair, hypertension, and non-resection of primary repair, even the systolic blood pressure at the follow-up, and absence of beta blocker therapy. That can increase the rate to come back for the reoperation. So in conclusion, once after I review all the study, we should summarize to each patient, because if we look at the case one patient, we see that 75 years old patient has a lot of disease, and maybe just only the interposition graft that should be done. And we should evaluate about yourself that how much you can do. If you just want to start the first one for aortic valve sparing for this for the first time of the valve sparing with this aortic type A, this can be not appropriate. For the second case that I show you, we did the Bentau operation with the mechanical valve, and the patient still alive for 7 years post-valve. The last one, our team did the valve replacement and interposition graft. The patient can still survive, baby still survive, and we're gonna make an appointment for the deliver the baby in next month. So many things that I learned not only for that. So I get some advice for the young surgeon that I can have give this one for you, that in cardiac surgery, success is ultimately in the details. it's good to learn from your mistake, but better to learn from someone else. So you should read a lot and learn from someone else's mistake. Some words that I can hear that surgeons who don't examine their mistake are destined to repeat them. Making a procedure more complex doesn't necessarily make it better. Dr. David just told me when I want to talk this one, he said just simple operation, interposition gap, and let the patient survive. That's going to be good. Remember that it is not generally easier to stay out of trouble than it is to get out of trouble. And don't forget that very bad outcomes can occur even in the hand of very good surgeon. That's I use many times when I decide what to do for the patient. The better you are, the luckier you get. And the last thing is sometimes better to be lucky than good. Thank you very much.
Thank you very much for the nice review and presentation. Is there any question from the floor, please? We have 3 minutes left. Okay, if not,